welcome to your critical care preclinical assessment video. I'm going to take you through a head-to-toe assessment on an ICU level of care patient. I'm going to begin by going over the things that are attached to the patient up here, and then we'll move on to physically assessing the patient. We're going to start with the cardiac monitor here. The very first row that you see is your patient's EKG. That measures their electrical rhythm. That is the rate, 79. Should match the pulse rate of 79, which is coming off their pulse oximeter. The second line is their O2 sat, which is coming from their pulse oximeter monitor they have right here on their left hand. That's where the pulse is picking up. It should match the electrical rhythm. The next line is the arterial blood pressure line, currently reading 116/78 with a mean of 91. The next line you have is their central venous pressure, which is the right atrial pressure, which is being measured off their central line in the right atrium of their heart, the current reading of 6. You will not record the respiratory rate that you find on the monitor. You will always take it from the ventilator. Non-invasive blood pressure cuff. This was the last time the blood pressure cuff was cycled. Patient's blood pressure was 120/80 with a MAP of 93. The reason why we cycle this at least once a shift is to correlate it with the artline blood pressure to make sure that we're getting MAP that's within 5 points of one another, and it's got to be run at the same time you zero in level. From there, I move on to looking at the IV pull and the items that we have on here. Start with what's up here up top. Very first thing, we have their tube feeding. This is going in an oral gastric tube. The type of tube feeding should be on the label or on the pre-printed bottle. Pivot 1.5. It was hung this morning at 9 o'clock. If it's a bag in tubing, it's only good for 24 hours. If it is a hard container that you spike, it's good for 48. Currently running at a rate of 10 milliliters per hour. Then we'll drop down to the infusion pump. And what we have on the infusion pump, the first item is Levophed. The Levophed is running in through here. I've chased it all the way back to here. Norepinephrine is the other name. It's running at 5 mics per minute. So that is the rate. That is the dose. It gives you the drug and the dose. That's more important than the rate. This you use for eyes and nose. This you use for your calculations for drip changes. This one is running fentanyl, and it is currently running at 5 mics per kilo per hour. Again, rate and then drug and doses on the screen here for titration purposes. This medication assists with keeping blood pressure elevated. This is a pain medicine that's also often used as a sedative for ventilator management, post-operative pain, several other things it's used for. This is where your pressure lines are. You've got your CVP and your arterial line that are both here that are generating the two waveforms you get up there. Then the last piece of equipment we'll take from what's connected to the patient is the ventilator. Off the ventilator, you're going to be responsible for obtaining the mode. Current mode is AC, which stands for assist control. The delivered rate, respiratory rate of 12. Tidal volume, it says 0.5. It's measured in liters. We document it in milliliters, so it's 500 milliliters with a PEEP of 6 and an FiO2 or delivered oxygen of 21%. The patient's respiratory rate, which is 12. So this is the patient, this is the ventilator. The patient is currently not overbreathing the ventilator, so he's not taking any additional breaths per minute other than the ones being delivered by the ventilator. That's all you'll be responsible for taking off the vent. The first thing that the nurse is going to do after she takes shift change report from the night shift nurse when she gets ready to do her assessment is determine whether the patient is stable enough to have a sedation vacation. Primary purpose behind sedation vacation is to assess for weaning from the breathing machine or the ventilator. Secondary reason for doing it is to get your underlying neuro. In order to do a sedation vacation, she can do one of two things. She can turn her sedative drip completely off. She can pause it or set a delay on it. If she's going to do that, she'll proceed to allow the patient to wake up and continue assessing other things. Your responsibility is going to ask the nurse, are we doing a sedation vacation today? If she says yes, then you just wait until it's done. You'll collect your neuro exam then. If she says no, you're just responsible for asking her why you're not doing one and documenting her rationale why. And then the only thing you will probably do is a pupillary exam. So to determine whether one would even be indicated, the first thing you're going to do is you're going to talk to your patient. Mr. Jones, Mr. Jones. Mr. Jones does not reply to your verbal, then you're going to take and gently, to try and get him to open his eyes, you're going to take a finger and just squeeze on the sides. They do not recommend nail pressure anymore. They just recommend that you just give it a squeeze on the sides to see if he'll open his eyes. Mr. Jones is not going to wake up with my verbal stimulation or my gentle peripheral tactile stimulation. I'm not going to do central pain, which is now recommended to be a squeeze here. As long as the patient is on a sedative drip, you do not cause pain when you are chemically restraining a patient. So for his neuro exam, all we're going to do is take a look in his pupils. So the first thing I'm going to do, I'm going to have to assess one pupil at a time. I'm going to be using the size chart on the size of my pen light. I'm going to lift the eyelid, and I'm going to look at the size of the pupil. The size before is what I'm worried about, not the size after. I'm going to do the same thing on the other side. And then I'm going to lift the eyelid, come across here, and I'm going to come over here and do the same thing. And then I'm going to record the size and the reaction of his pupils. As I proceed, I'm going to proceed in a physical head-to-toe manner. So I started with the pupils. The next thing will be the assessment of his artificial airway. This patient has an oral endotracheal tube in. He also has an oral gastric tube in, which is the same thing as the nasogastric tube. It's just placed orally. The endotracheal tube, on the size of the tube, right about here, you will find the size. The size of this particular tube is at a 7.0. The adult size average between 6 and an 8. You also need to measure the depth. And the depth will be either to the teeth or gum line if they don't have teeth, or the securement device if it is something that is hard like this. And that measurement is on the side, and that's at 27. So you have a size of 7 millimeters, and you have a depth of 27 centimeters. The oral gastric tube is verified via chest x-ray only. We no longer inject air, pH test, or do any of those things in the adult critical care setting. So the last chest x-ray that was done for placement determines that it was in its place. Not necessary to record depth, size, or anything with this particular tube. What your responsibility with that is to check your residuals to see how your patient's tolerating tube feeding. Usually your nurse will already have a 60 cc catheter-tipped syringe in the room. If there's not already a towel beneath it, you want to get one, or you're going to make a mess all over their bed. This has what's called a Lopez valve, which is this section on it right here, that prevents you from making quite the mess because it doesn't have to be disconnected. Cap comes off the Lopez valve. It can be stored right there so you don't lose it. You attach your syringe here. Stopcock says off. You turn it off to the tube feedings, which is back there. The pump will not alarm because the pressure is not high enough on the pump. Gently pull back on the plunger and continue to pull as long as you're getting gastric contents. If you fill the syringe with gastric contents, lock it back off. You're going to take the syringe, you're going to empty it into a graduated cup and continue to draw it out until you've removed all the residual that's in their stomach. Once you've completed that, usually between 300 and 500 is the maximum amount of residual. Most physicians keep it around 300. You will put 300 of what you've taken out. You'll discard the rest. You'll notify the physician and the nurse about the amount of residual because your patient is not tolerating their tube feedings. So 300 goes back in, everything else gets discarded. And then you want to replace your cap, and then that's automatically going to start again, but if your residuals are that high, it's going to need to be turned off. This portion of your oral gastric tube here is called your Salem sump. This is the sump function. The purpose of this is to allow gas or air to escape out of their stomach. It is important that this line is clear. If you see gastric contents, medications, or feedings or anything in it, this needs to be removed. You need to draw back 60 milliliters of air, stick it in here, and flush the air in just as rapidly as you can. As soon as you take this off, you should hear the air escaping. You have returned the sump to its proper function. Blue connects to blue. The white has the little holes that allow the air to escape. If this is dropped below the level of the shoulders, it's just going to fill right back up with gastric contents or tube feeding. So you want to keep this sump up here above the level of their shoulder. Next thing we're going to do is move down and examine our patient's chest. If he has a snap gown, you'll just unsnap the gown, keeping in mind you want to keep them covered as much as you possibly can. I have two types of stethoscopes here so that you're aware of the function of yours depending on which head that you have on yours. If you have one that looks like this, or one that looks like this. If you have one that looks like this, the diaphragm works just by gently laying it down, the bell with gentle pressure on the top. If you have one that looks like this is the diaphragm, this is the bell. In order to activate the bell, you actually have to turn it. You'll see a hole in the base there. Tap it and you should be able to hear it. So that's the difference between the two functions of those stethoscopes. Ear canals go like this, so your stethoscope goes in your ear like this. I always tap, make sure it's loud and it's working. You can start with heart sounds or lung sounds. You're going to do both while you're here, and we're going to take care of everything on their chest wall. If you're going to do heart sounds first, you want to take clavicle, you want to follow it down to the sternum. You're going to roll over your first rib, roll over your second rib. You'll be at your second intercostal space on your right sternal border. That's your first landmark. You're going to listen long enough to determine regular and rhythmic. Lub-dub, lub-dub, lub-dub. Do you hear any extra heart sounds? If you have a stethoscope like this, gently apply pressure. You'll pick up the bell in order to hear any murmurs or extra sounds. If you have a stethoscope like the other one that I had, you'll wait and come back and do it with the bells. Then you go directly across the sternum. This is the next location. Follows the acronym 8 to man. So we have aortic, pulmonic, Erb's point, tricuspid, and then the mitral. Then you move down. Again, each spot, regular and rhythmic, move to the next spot. 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 You apply pressure for the bell. Now, if you have the other stethoscope, you're going to go ahead and turn it at this time, and then just follow your path back to pick up any extra heart sounds. Aortic valve, pulmonic valve, Erb's point is where you hear the entire cardiac cycle the loudest. Then tricuspid and mitral. Next thing, you listen to lung sounds. On a sedated, bedridden adult ICU patient, we are not going to reposition this patient on their side to listen to posterior sounds. Most of the time, the nurse is not going to do that. Most of the time, they're probably not even going to do a real good job with the laterals. So for your anterior sounds, you're going to compare them side to side, and we're going to primarily focus on lung fields. So one ventilation cycle to hear the entire cycle, then move. Same thing there, drop down, same thing, drop down, and then there. So it's one full ventilation cycle with each of those 6 spots. Not necessary to listen up here or listen up here. Next stop would be the laterals. On the left lateral, you're going to do a backward C. On the right lateral, you're going to do a Z pattern, 4 spots. You get up underneath their armpit, basically, and you do 1, 2, 3, 4. That allows you to listen to the right middle lobe. Otherwise, it will not be heard anteriorly or posteriorly. And then on the left side, you're going to start in that same location, and then you're going to go around in a backward C to get the lung sounds around the heart. 4 points. 1, 2, 3, 4. Again, each spot, one full cycle. All right, just concluded listening to lung sounds. Patient's lungs sound a little bit wet, and I think they might need to be suctioned. So I'm going to go around to the ventilator, and I'm going to hit the suction button on the ventilator, and it's going to put them on 100% oxygen for 2 minutes. I'm going to wait that 2-minute cycle, and then I'm going to proceed to suction my patient. The 2-minute cycle concludes, and I'll know it because the lights will go off. I'm going to put them back on the suction button. It's going to silence the alarm for me. I want to make sure I have the airway, which is ear down, and the vent circuit secure in my hand. I want to make sure my suction's up and running and I can hear it. Prepare my patient that I'm going to suction them. Expect that they will cough. I'm going to advance the inline suction catheter until I meet resistance so the patient begins to cough. And then I'm going to apply intermittent pressure as I remove it out. From the time that I begin this to having it back in its original position can take no more than 10 seconds. And I can go down no more than 3 times without having to reoxygenate. I only go down as many times as I need to clear their secretions. This just locks it so that if it gets stuck in the bed rail, it can apply continuous suction. Then you just kind of take a look at the skin. Is there anything that you need to pick up? We've got one thing here. This is a 1, 2, 3 triple lumen central line located in the right subclavian vein. The site is clean, dry, and intact. The dressing just got changed this morning. If I wanted to trail back and know what everything was hooked up to, this would be now the time that I would actually follow the lines back to their source. This is my fentanyl. This is my norepinephrine, and this is my CVP line. Alright, and so that's the assessment of our central line. On this side of the chest, down in the lower portion of the chest, and I'm going to access it coming from the other direction, there is a chest tube dressing. Chest tube should be secured to the drainage tubing here by having it taped all the way around so the connection can't come apart. Should also be secured to the patient so that if I accidentally do trip over it, it won't come out. And the dressing should be clean, dry, and intact. Do not change it unless you have orders to change it. Sometimes the doctors like to be the first ones to change it, and they just ask that it get reinforced. There should be no loops of the tubing in the bed. When assessing the drainage, you need to assess the drainage in the tubing, not the drainage in the container, because you don't know how long the drainage in the container has been there. This particular chest tube drainage system is called a dry system. This system, the suction is controlled by that suction regulator right there. It has a little spin dial on the side that you can turn that allows you to change the amount of suction. Positions, usually standard order, 20 centimeters of suction. If the suction was on, this would be connected to the wall suction, and you would see that little accordion that's orange in there would fill up at least half the window. This is the water seal chamber. Bubbling in the water seal chamber is abnormal. That means there's some kind of air leak within the system. And then this is the old drainage that is collected over whatever time period it's collected over. But again, you assess the drainage in the tubing for drainage characteristics. Okay, the next stop we would be moving on to the periphery. I neglected to do skin turner when I was up doing the chest wall. So right directly underneath the clavicle, you're just going to lift a pin to the skin and let it recoil. If it stands up, it's tenting. If you let go, it's instant recoil or elastic. Then we're going to move down to the abdomen and the periphery. And whether you do the arms or the abdomen next is up to you. So first thing you're looking at is your abdominal shape. And so this patient's abdomen is round. Round, flat are both considered normal findings. I do not see any masses, and you don't actually touch it. I was just trying to make the skin go flat. I do not see any masses. I do not see any central pulsations that would indicate he could possibly have an abdominal aortic aneurysm. The next thing after you do your inspection, you want to listen with your stethoscope, and you want to make sure if the last thing you did was heart sounds and you had it on the bell, turn it back to the diaphragm and tap it really good. Always start in the right lower quadrant. You very gently lay it on there. Never push in. You'll alter the noise. and you listen long enough to determine the presence, whether they're active, hypoactive, or hyperactive. It is imperative that you want to call them, if you would like to call them hyper or hypoactive, that you count. You start the clock at the second hand, and you need to count for 1 minute in this quadrant. If you hear less than 5 sounds in that minute, it's hypoactive. Greater than 30 sounds, hyperactive. If the remaining 3 quadrants sound the same, reasonable and prudent nurse can call them all the same thing. Then you move on and listen to the next one, and the next one, using your belly button as your landmark. If you have an obese patient and their abdomen is somewhat displaced, you're going to have to kind of use a bigger landmark than their navel. Also, when listening to abdomen on an obese patient, sometimes it's easier to hear if you go from the sides on those quadrants. You still do not apply pressure. Pushing on fat just squishes fat, so you don't want to do that. All right, abdominal assessment's done, so we'll move on to the periphery. This patient has a saline lock in their right antecubital space here. It is timed and dated, and it is a 20 gauge. I can also tell by the color, pink, and there's a color chart. All hospitals use a universal color. In order for me to determine whether this is still a good IV, I'm going to need to clean it with alcohol. I need to take flush. I've unclamped that there. I'm going to need to flush in 5 mils of saline, draw back, make sure that I get a blood return, and then I can flush the additional 5 mils. If I do not get a blood return, then this IV is no longer patent and needs to be removed. Next stop is going to be here underneath this wrist restraint. Wrist restraints need to come off to have the skin assessed underneath them. You quick release it from whatever mechanism it needs to be separated from underneath the bed, just never attached to the bed rail. This patient has a arterial line. It is located in their right radial. The site is clean, dry, and intact, and that's what was giving us our continuous blood pressure reading up here, was coming from this line. If it is really close to the wrist, you're not going to be able to get in between it and the wrist to get your radial pulse. If not, then you will be able to stick your finger here and assess for the radial pulse. And remember to use your middle finger. It's the only one that does not generate a pulse in the tip. So I'm not going to be able to get to it because it's too close to the wrist. So I'm not going to be able to get a radial pulse on this arm, and therefore I'm not going to document one. Then I'm going to do cap refill and just give a gentle push and check to make sure that that's okay. Make sure that skin's intact underneath the restraint, and then I'm going to put the restraint back on and re-secure it. Purpose for these restraints is if he does wake up, it'll prevent removal of his artificial airway. You want to make sure the restraint is where you can take 2 fingers, run it down the inside of the restraint so that it is not too tight, doesn't cut off circulation. And then you just want to re-secure your restraint the way you had it with an easy remove knot. The other side, you're going to want to do the same thing. Come over, take the restraint off, take the skin out, take a look at the skin, palpate the radial pulse, and be able to document your findings, check your cap refill. If they've got a paper one of these on there that's stuck to it, then you're not going to be able to check it on that particular finger, so you can check the skin on the side of that finger, and that will suffice. Look at the extremities for any kind of edema, skin tears, or anything else that might be going on with those extremities. All right, and then the last thing, as we move down, continue moving down his body, we will take and bring his gown up. If he has on SCD sleeves, you need to remove them, or TED hose, and take a look at the skin underneath. If he has on socks, heel protectors, or anything, it needs to come off so that you can take a good look at his skin. So we'll start by assessing them. This is where I will get gloves on. So you get appropriately fitting gloves. Make sure that they're not too big, not too small. You want to put gloves on, and you want to take a good assessment of their peri area to make sure that the skin is intact and there are no signs and symptoms of infection or breakdown. On a male patient, you want to make sure to check around there for any drainage. You want to make sure to look down here and make sure there isn't any stool or anything else from the last time they've been cleaned. You want to take a look again when you're looking at fluids that's coming out from somewhere, what's in the tubing, not what's in the drainage bag. I have a very scant amount of clear, pale, yellow urine here, and then whatever's in the bag. The size of the Foley catheter is written on the side of the balloon port. You will be responsible for knowing what size Foley your patient has in. This particular patient has a 14 French. The Foley is supposed to be secured to their thigh to prevent any trauma in case it gets caught or pulled. And so if your securement device isn't holding really well, then you need to remove it and get a new one and clean really good. Take a look at the skin here and here. To check for pretibial edema, you need to find the tibial, which just runs down the front. Gently roll your finger off to the side and apply some gentle pressure. If it feels very bouncy, then you may have some pretibial edema. Again, there should be no dependent loops in this. It needs to be secured to their thigh. And then our last stop is going to be to assess the pulses and cap refill on their feet, and also assessing for edema. Couple tricks that I can show you here that will probably help out. Alright, so when you go to assess your dorsalis pedis pulses, if you find that bone that sits on all the top of our feet right there, slide your fingers just below it and to the right, boom, there's your pulses on 90% of the patients. And then when you go to get their post-tibial, if you take and slide your hands around their ankle and feel right, find their ankle bone, move your finger 1 finger breadth behind the ankle bone, light pressure, or you can occlude it, and you should be able to find their post-tibial pulses. And then again, cap refill can be nail bed. If they have thick nails, if they have polish on, then you'll have to get it on the tissue, on the toe, or on the side of the feet, and then you're done. Now the last thing, first thing in the morning at 8 o'clock, your patient will be due for a turn. If they are bedridden on a ventilator such as this, they will be required to be turned every 2 hours. When the nurse goes for the first turn and has you help assist her, that's when you will examine all the skin on the back side of the patient. If there is a dressing on their coccyx area, it's going to need to be removed so you can see the skin underneath. Remember, if the skin is red but intact, you need to apply gentle pressure. If it blanches, it is not a decubitus. If it does not blanch, that's a stage 1. If the skin is broke and it's red and does not blanch, it's a stage 2. Anything after that wouldn't be comfortable trying to stage without the nurse's assistance. When you have a patient who has pressure lines, this particular patient has an arterial line and has a CVP line. Ideally, they've got a level on your unit where you can level this to your patient. Most of these have disappeared over time, and so the moral majority of us do leveling with the naked eye, unfortunately, now. So in order to be able to do that, you're going to want to make sure your tubing is all clear of your bed rail. Drop your bed rail. It is going to be leveled to your 5th intercostal space, mid-axillary line. So you're going to go to mid-axillary, and you're going to start rolling over the ribs until you get down to the 5th intercostal space. When you get down to the 5th intercostal space, you're going to want to take your level, put the bubble where it belongs, and that should line up right here with that stopcock. If it lines up, then it's been leveled. If it does not line up, then you need to go ahead and move this. There's a way to do that on the back side. Open it up, move it, and then close it back. It has been leveled. Your other responsibility with it is these 2 particular bags right here. One of them for the art line, the other one's for the CVP. Both of them have to have only normal saline in them. Both of them need to be pumped up to the green or 300 millimeters mercury of pressure. Stopcock needs to be turned off to this bag to keep the pressure in it. That's what allows us to get those readings. And so as long as there's fluid in the bags, they're pumped up to 300, and both of them have normal saline, they are set up correctly and good to go. If this is not a 300, open the stopcock, apply more pressure until you get it to 300, and then raise it. Most of them have a safety valve on the top. If you pump it over the 300, it will automatically self-deflate for you. Now that you have leveled it, you've determined you have the right fluid at the right pressure, you will take, and the next step will be to zero these. That's part of your assessment. You turn your stopcock off to your patient. You will remove this cap. It's important that you don't touch that because that's sterile. It's going to attach to their IV. You give a gentle little tug on this rubber thing to pull fluid out to the tip, and you go up to the monitor here, and you hit the line that you're working on. If it worked, you hit the line that you're working on. A menu comes down here, right here where it says zero pressure. You hit 0, and that'll say 0 over 0 over 0. The moment you turn the stopcock, that goes flat, and there'll be 3 zeros there. Right after you hit 0, they all 3 0. Then you're going to close your stopcock back off and put your cap back on, and repeat the same process with the other one, which will do the same thing to the CVP. And then you have zeroed and leveled your lines at the beginning of your shift to make sure that they're calibrated to the atmospheric pressure. And if you've thought of anything that I've forgotten, you'll have to be sure to tell me that first day at the Smart Hospital. All right, now, if you take your documentation forms that your various instructors will have you using into the rooms with you, except in an isolation room, cannot take those in a room and patient in isolation, you will write down this information as you collect it. You'll collect as much information as you can in here at one time, and then you'll get it recorded, and then you'll continue on. You'll also use those forms to kind of help you determine what you might have skipped, like I did with the skin turgor, to go back and pick up. I typically record everything from here, and everything from there, and then I move on to my patient. And whether I've got to stop and record any of it depends how much is really going on with my patient. Okay, for the first part of report, I am going to have to be looking at the monitors because I didn't write anything down. So I have an EKG rate of 80. Looks to me like it's probably normal sinus rhythm, but I won't know until I print the strip and do the measurements. I have an O2 sat at 97%. I have an arterial blood pressure of 128 over 81 with a MAP of 94, and I have a CVP of 6. If I leveled my arterial line, I also recycled my blood pressure cuff at the same time, and I got a blood pressure cuff reading of 120 over 80 with a MAP of 93. Because the MAP of 91 and 93 are within 5 points of each other, they're considered correlating. And the waveform on the monitor looks like a mountain, meaning it's peaked, so that is an appropriate waveform. It's not flattened out or dampened like a mountain or like a hill. Then I would go over to the pump and document what I had there, which is my Pivot 1.5 at 10 mils per hour, my norepinephrine at 5 mics per minute, and my fentanyl at 5 mics per kilo per hour. Then I would record what I pulled off my ventilator. I have AC rate 12 over 12, which is the delivered over the total, tidal volume of 500, PEEP of 6, FiO2 of 21%. So now that I've got that all written down, then I can plug it in where I need to give you a good head-to-toe report. So we'll start with vital signs. So we have heart rate 79, respiratory rate 12 over 12, blood pressure 116 over 77 with a MAP of 89. We have a temperature that I would be able to get with a thermometer very gently just underneath the back corner of his tongue. Not a big deal because he has the ET tube in place of 98.4. Pain, I have no signs and symptoms of pain. Signs and symptoms of pain include facial grimacing, restlessness, agitation, elevation in vital signs, unless there's an underlying factor that I know is causing them to be elevated. The patient is on a fentanyl drip, which is probably why he's not experiencing any pain. And I would report the 5 mics per kilo per hour at this time. Fentanyl 5 mics per kilo per hour because it is affecting his pain assessment. Neuro, patient is sedated, again on the fentanyl drip per nurse. Sedation vacation will not be done as the patient does not tolerate well. So patient unresponsive to verbal and gentle tactile stimulation. Pupils were 4 millimeters and bristly reactive, and that's GCS. is going to be 1, 2, 3T. So you got a GCS of 3T, and I'm going to be unable to assess anything else under neuro for this particular patient. If he was a neuro patient, I would also make note whether there was any facial drooping present or if he had any seizures, but he's not a neuro patient. Cardiac, S1, S2 auscultated, no extra heart sounds or murmurs heard. EKG was normal sinus rhythm. I would print it out. I would measure the PR and the QRS and report both of those measurements at this time. Radial pulse on the left was 2+, right unable to assess due to art line. DPs and PTs were also 2+. He had no edema. Skin turgor was elastic. Cap refill, less than 2 seconds, times 19 digits, because I couldn't get underneath the pulse oximeter. I don't know if I said no edema noted. Art line, right radial, clean, dry, and intact. Good waveform, correlates with the non-invasive. Respiratory, lung sounds, coarse and wet throughout. 21% per vent for oxygen. Effort is even and unlabored, or you can say effortless and symmetrical. He has a artificial airway in. It's an oral endotracheal tube, or ETT, size 7, 27 centimeters at the securement device. He has a weak cough with suction, the scant amount of clear white secretions. GI, abdomen is flat or round. Abdomen is round, no masses or pulsations noted. Bowel sounds were active in all 4 quadrants. I forgot to palpate his abdomen, so I'd have to go back at this time and palpate his abdomen for soft or firm or distended. And firm and distended kind of go hand in hand. He has an oral gastric tube connected to pivot, 1.5, running at 10 mils per hour, and he had a residual of 20 mils. GU, he has a 14 French Foley to gravity with scant amount of clear yellow drainage in the tubing, but he's averaging about 30 mils per hour based on what's in the container and the amount of time it's been in. Musculoskeletal, he's got soft wrist restraints on to prevent removal of his tubes and lines. I'll be doing passive range of motion exercises, and that's pretty much all I'm going to cover under musculoskeletal. Might add in your SCDs if your patient had on SCD sleeves in that section. Integumentary, calculate the Braden scale. His skin is white, warm, dry, and intact except for his chest tube, which I can either pick up here under skin or I can go back and cover it in respiratory. The choice is yours. He has a left lateral chest tube that's clean, dry, and intact with no drainage in the tubing, old drainage in the container, currently to water seal with no air leak because there wasn't any suction hooked up. And his IVs also go under integumentary. I have a right subclavian triple lumen catheter that's clean, dry, and intact. I have a right AC 20 gauge saline lock, also clean, dry, and intact. All right, I think I'm done.